What are the hemodynamics of VSD? A ventricular septal defect causes left ventricular volume overload, and this means, again, overcirculation of the pulmonary arteries. But now we have not only volume load to the pulmonary circulation, but also pressure load, and this apparently makes a big difference to the atrial septal defects. And in these patients, as soon as we have a significant size of a ventricular septal defect, they all develop pulmonary artery hypertension, and as soon as they reach adulthood, most of them will have severe pulmonary vascular disease and will develop Eisenmenger syndrome. Color Doppler is very helpful for detection of the flow, particularly as long as we have a significant pressure difference between left and right ventricle. It becomes more difficult when we have severe pulmonary hypertension and Eisenmenger syndrome, but in all the patients with a high gradient between left and right ventricle, we will see a high velocity jet from the left to the right ventricle, as in this example of a trabecular ventricular septal defect. Another term is that we talk about restrictive versus non-restrictive defects. Restrictive means that there is still a significant pressure difference between left and right ventricle, and this means that we have high velocity when we measure the jet velocity with continuous wave Doppler, as seen in this example here. We talk about a non-restrictive VSD in patients who have developed severe pulmonary hypertension or and this causes a low velocity only between das müssen wir raustun, wenn wir nochmal neu anfangen. Wir steigen bei dem Non-Restrictive nochmal ein. Ne? When we talk about non-restrictive ventricular septal defect, this means that there is no longer a significant pressure difference between left and right ventricle. This is the case in large defects when the patient have developed severe pulmonary vascular disease and have developed Eisenmenger syndrome, and this is typically then followed by a shunt reversal, and the patients will develop a bidirectional and eventually net right to left shunt, and this will cause cyanosis, and this is then the typical aspect of Eisenmenger syndrome. Now we could theoretically use these velocities measured with continuous wave Doppler to calculate the pressure difference between right and left ventricle. For example, having a VSD with a high velocity of 5 meters per second, this means that we have, using the Bernoulli equation, a gradient of 5 squared times 4, so 100 millimeters mercury pressure difference between left and right ventricle. Now measuring the systemic pressure non-invasively, and let's say we find 120 millimeters mercury, we could assume that this is also the pressure in the left ventricle as soon as we have excluded aortic stenosis. Now subtracting our difference between left and right ventricle from the systemic pressure should actually give us the right ventricular pressure, which in this case would be 20 millimeters mercury. Unfortunately, that's not that easy, and VSDs can have a more complicated flow through a channel that causes pressure recovery and all kinds of phenomena, and this means that this calculation is frequently wrong, and we should not be surprised to find patients with a systemic pressure of 120 millimeters mercury, but a calculated pressure difference between the ventricles of 140 millimeters mercury, which of course would then be impossible because we would have negative right ventricular pressure. So we should be careful with these calculations, and accurate measurement of the right ventricular pressure is probably not possible by this formula. As mentioned before, in the patient with non-restrictive VSD, large VSDs, we have low velocities, less than 3 meters per second. How can we quantify the flow? Theoretically, we could again use flow calculations in the pulmonary artery and in the left ventricular outflow tract or the aortic valve. Unfortunately, in many of these patients, we do have turbulent flow in the pulmonary artery due to the VSD, so it's not that easy, and in many patients not really accurate. It's worse here than in the atrial septal defect, and in most patients not really useful. So what's most important here is to look at the volume overload of the left ventricle to know about the hemodynamic significance of this ventricular septal defect.